The Robert Graham Centre is a partner institution with FACRRM based in Washington DC, and it's funded by the American Academy of Family Physicians, which is equivalent to the Australian College of General Practitioners. And we've had a relationship with them for some years. Lachlan is the fourth of our fellows, and it's been a very successful partnership. Lachlan has recently completed his specialty training with the Australian College of Rural and Remote Medicine in the Torres Strait, and he did our fellowship late last year, which was about a month in Washington DC, and he's off shortly to a new position as Climate Change and Health Officer with the World Health Organization in Suva, Fiji. So Lachlan is going to talk about his project that he undertook in Washington DC with the Robert Graham Centre under the heading Epidemiology at the Extremes, an examination of the factors that affect health outcomes in remote Australia. So please welcome Lachlan McIver.
Thank you, Bob, for that kind introduction, and thank you all for turning up. I appreciate it's a warm afternoon. You probably all just had lunch, and there's other places you'd rather be. So I appreciate your attendance here. Disappointed, of course, I can't use my MacBook. The fonts, I promise you, are a lot sexier in Mac format. So, as Bob mentioned, I'm going to talk to you about a project that I did with a couple of colleagues from the Robert Graham Centre in Washington DC, Dr Steve Pedersen, who's the research director there, and Sean Finnegan, who's an up-and-coming GIS guru there. I'm very grateful for the opportunity to do this project, courtesy of funding from the Department of Health and Ageing, FACRRM, and the Robert Graham Centre. I won't go into my background anymore. Bob's done a great job at sort of summing me up. That's a little picture of me in my last day job as a senior medical officer up in the Torres Strait. Look, just a brief disclaimer to say that while the project was supported by FACRRM and Doha, as soon as I get a little bit controversial, they'll disown me, which is kind of them, and fair enough too. To give you some idea about the rationale for this project, it had been my experience, and certainly that of many others, that not only was the differences between the health outcomes in urban and rural communities a difficult and ongoing challenge, and the reasons for that are myriad, related to everything from geographic isolation to health workforce problems, infrastructure, lack of resources, health risk behaviours that differ in rural areas, and many other factors, and that this so-called rural-urban health differential is not necessarily a universal phenomenon. Doesn't apply in all communities. The trend isn't linear. That is to say that health outcomes don't incrementally worsen with increasing remoteness, and that it's not all bad news in rural areas. There are certainly some protective effects of residing in these areas. And there's also the issue, of course, related to the contribution of indigenous ethnicity to these different health outcomes in rural areas. When we're talking about remote and very remote Australia, we're talking about a population that is majority indigenous in many of these communities, and there is certainly little doubt that the overwhelming burden of poor health that's borne by the indigenous community contributes, at least in some part, if not in large part, to the poorer health observed in these communities. So while that rural-urban health differential has been described and discussed elsewhere, it was really the situation in those most remote communities that I was interested in, to see whether there were differences within that group. That had certainly been my observation. That could be examined in a sort of statistical epidemiological sense. The final note on that slide is just to point out that there's been some interesting research done into the effect of indigenous ethnicity and remoteness that would suggest that the two effects may in fact compound each other. That is, the cumulative effect being more significant than either alone. So, as I said, my interest lay in those the most remote communities, and I took issue with this idea that often, and particularly in a sort of in a political or policy sense, that those very remote communities were all sort of lumped together. And while no one was necessarily arguing that they were a homogeneous group, that they were treated the same because of this shared characteristic of being very remote. So, I was sort of driven by this idea that, that they definitely had very different health outcomes, and it was the reasons for that I was most interested in. So I thought this quote, which is a significant paraphrasing, was relevant. That all very remote communities, while often being treated as equal, some are more equal than others. Now it's attributed to Napoleon. Would anyone speculate as to which Napoleon I'm referring there? Very good, sir. Give that man a chocolate frog. So Napoleon the pig from George Orwell's Animal Farm, of course, had the original quote of all animals being equal, some more equal than others. So that was sort of the background as to why I was interested in this project. So what the idea that we came up with to do was to look at those communities that were among the very remote, the most remote in the country, compare health outcomes between them, compare the differences in those health outcomes to some sort of social epidemiological variables that we could find for them, and to have a play around with various methods by which we could identify which communities were performing differently to that which could be expected based on their epidemiological risk, with the implication being that by doing so and identifying these sort of these ones that were behaving in an unexpected fashion, that this would be useful to direct health policy planning and address those imbalances. It's an important point to make at this time that I'm going to more or less use the terms community and SLA interchangeably. An SLA is the unit of measurement that we're using for this. It's a geographical area, and in non-census years is sort of the smallest geographical area used by the ABS for data collection purposes. The country is divided up into SLAs, and they are subclassified into 5 sort of categories of remoteness, going from major cities through inner and outer regional, remote and very remote. And it has been pointed out by sort of experts in this field that the system is far from perfect for the purposes of health research or policy planning, which has led to the development of other more specific indices of rurality in the context of health. But for the purpose of this project, we need to acknowledge that an SLA does not necessarily represent a true community in the sort of social or geographical sense of the word, but it's the closest we could come. And each SLA has a population. For the very remote communities, we're talking of several hundred, up to sort of around 1,000, and that geographical area may in fact include one or a small number of actual communities, particularly in remote indigenous areas. Please just put your hand up and ask questions or make comments along the way. I'm happy for this to be a really sort of free-flowing exchange, and I'll of course take questions at the end. But if something I'm saying isn't making sense, or you want to take issue with something, please just put your hand up or sing out. Okay, so to give you some idea about where it is that I'm referring to. This map is taken off Health Landscape Australia, which is a GIS health data mapping tool that's currently in development by my colleagues at FACRRM. And I've chosen this map to give you an idea about where we're talking about and one of the key characteristics of those areas. So the vertical stripes are those communities that are classified as very remote, so the most remote category in that Australian standard geographical classification for remoteness areas scale. As you can see, it incorporates about 2/3 of the geographical landmass of Australia. The population therein is in the order of about 1% of the total Australian population, but includes about 18% of the total indigenous population. So, and what is underlying that in the chloropleth scale is those darkest green areas are those with at least 40% or more of the population in those areas who are indigenous. So the point obviously there is to demonstrate that when you're talking very remote, you're really talking a high proportion of the population who are indigenous. So the first step in the process was to identify all those SLAs or communities that were in that very remote classification, and see what data was available in terms of the social epidemiological variables for those communities. And the majority of that data was sourced from the wonderful people at the MPHTM at the University of Adelaide and their Social Health Atlas of Australia, which uses 2006 census data and other health data collected over a sort of 2003 to 2007 period, averaged annually, and put into their atlas of last year. This is one of the maps that we made, and that's just to demonstrate of all the very remote SLAs, that's those highlighted in either blue or grey, which ones were eligible for inclusion in our study. Those are the ones highlighted in blue. The ones that we couldn't include were those very remote communities for which there was an insufficiently complete set of data. So the grey ones we had to leave out. So there's about 137 or so very remote communities, of which we could include 84, and those are the ones highlighted in blue. So we've got a fairly good geographical spread throughout the country, but we of course acknowledge that those omissions in themselves may have had a profound effect on our results. So, I'll be making sort of caveats and disclaimers along the way that the results of the project are vulnerable to significant sources of error, and therefore open to questioning and criticism because of that. So we're really promoting this as a novel approach of analysing this type of information for these areas, rather than saying this is a definitive statement of the fact of the situation. So having identified those communities, we then needed to decide how we were going to compare them in terms of their health outcomes, and for that we chose avoidable mortality rates, which are indirectly age standardised to the sort of total population of the country. And even this was a sort of interesting process. We needed to decide which health outcome could lend itself to comparison, and we considered others, including life expectancy, crude death rates, or sort of using multiple health outcomes such as chronic disease endpoints. But in the end, we plumped for avoidable mortality rates. Firstly, for the practical reasons in that the information was available, as in it had been collected, and it was therefore comparable between communities. And also there was a precedent for its use in other types of studies that look to link up health outcomes with epidemiological factors and health service delivery. So there was sort of a consensus that in looking to compare the performances of health systems, that this was a reasonable measure by which to do that. So that's why we chose it. I'd be happy to talk more about avoidable mortality rates, with anyone down the track. Just to sort of point out that rather than being a death rate alone, it looks at conditions that are either preventable, i.e., could have been may have not happened in the first place had conditions been different, or amenable. That is to say that under the right circumstances, with the capacity of the health service, that the condition may not have occurred. So a brief example of a preventable condition would be, say, a smoking-related death due to lung cancer in a smoker, whereas an amenable condition could be a ruptured appendix leading to a death in the context of somewhere where that condition should have been able to be dealt with. So it's a measure really only applicable to developed world health systems where these conditions are actually amenable to treatment. Okay, and this is a quote from a paper on the use of avoidable mortality rates, just sort of pointing out that the precedents for its use that I had discussed, and the reference there for anyone that's interested. Okay, so look, I'm sorry that doesn't show up too badly with the white titles there, but this is just to sort of reinforce why our interests lay in the very remote communities. This table is of all the SLAs in the country, not just the very remote ones, in all 5 categories, the entire sort of country of Australia divided up by SLA. This is the top 20 SLAs by avoidable mortality rates, as in those communities with the highest levels of avoidable mortality. And you'll see in those last 2 columns on the right that of those worst communities, as in those with the highest levels of avoidable mortality, we're talking indigenous communities and we're talking remote communities. So this isn't just of the remote and very remote category, this is all the SLAs in the country, the top 20 by avoidable mortality rates. And this is sort of really the reason why I've chose to focus on the very remote communities, because they're so overrepresented in these poor health outcomes. So once we had generated this list of the very remote communities in the country ranked according to avoidable mortality rate, we examined that list more closely and realised that there was basically a big cluster around the middle, as in the majority of the very remote communities had roughly similar sorts of avoidable mortality rates, big group in the middle, and then these long sort of tails at the top and the bottom, if you like. And it was really these that held the most interest for me to say, look, why are some doing so well and others so poorly when this is a group that otherwise has so much in common? And as you've seen from the previous slide, that they're massively overrepresented in the overall list of the worst performers in terms of avoidable mortality. So finding out, who these communities were, where they were, and what the causes for their performance were was really the sort of one of the main aspects of the study. So this map demonstrates that the tails basically that I referred to earlier. So the red communities, I know it doesn't look like 20 there, some of them are very small, but the SLAs in red are those with the highest rates of avoidable mortality in the country, the top 20 in terms of avoidable mortality. The blue ones are those communities with the lowest levels of avoidable mortality. And for those of you in the room with something more than a passing familiarity with health in rural and remote areas will be able to begin speculating reasons why this may be so. So you have the territories in the sort of East Kimberley, East Pilbara region, the top end of the territory, down in the Central Desert, the Gulf and Cape York and the Torres Strait that are among the worst performers in terms of their avoidable mortality rate. And sort of the Western Queensland, west coast of Western Australia, some of these communities, you would be able to speculate some of the reasons why, these may be in the sort of best and worst. So this was just in terms of avoidable mortality rate. We then went and examined all those social epidemiological variables for which there was a sufficiently complete data set for these very remote communities, and tried to establish which factors were associated most strongly with the observed differences in avoidable mortality rates between those SLAs. And we did the analysis via two statistical methods, one being an analysis of variance and then another a factor analysis. And having looked at those variables, we ranked the communities again. We selected the top and bottom 20 and then selected the very middle 20, the sort of median 20 if you like, and compared the average values for each of those factors between these three groups to really try and demonstrate in the most sort of stark terms what the differences in the outcomes were in the variables for each of those groups were. So I hope I haven't confused you too much. This is the table of that. Now I've potentially used misleading terminology here. The top 20, that's the second column, is the 20 very remote communities with the lowest rates of avoidable mortality. Okay, so I've chosen to call them the top 20, and the bottom 20 being those with the highest rates of avoidable mortality. I hope you're all with me on that. And then the middle 20 being a sort of representative group around the middle. We compared each of these variables and looked at the differences in those variables between those three groups and had p-values to demonstrate the level of statistical significance. Is everyone happy with the concept of p-values? Is anyone not happy with that? Okay. So running down the list, you can see that, and now keep in mind that the values in each column are the average values for that group of 20 for each variable. Okay, so for the top line, avoidable mortality rate per 100,000, keeping in mind that from that earlier table you saw some of those worst communities had avoidable mortality rates well over 1,000 per 100,000. This is the average value for the worst 20 very remote communities, about 540 per 100,000. So of those worst 20 SLAs, they also had a much higher proportion of the population who are indigenous, a different sort of age breakdown, being a younger population. Who were largely less professional, lower levels of literacy, lower levels of employment, more at higher risk of living in a jobless family, less engaged in the schooling system, higher levels of poverty, more likely to have overcrowding and parents caring for other people's children, and belonging to single parent families. And those sort of measures of social difficulty were all very strongly correlated with the differences in health outcomes between the best and worst communities in this very remote group. We also looked at the end, the composition of the health workforce in these groups, which is obviously always of interest to particularly policy people as well as academics. And it's worth just sort of touching briefly on the health workers issue, just to say that in these very remote communities, as no doubt many of you will be familiar, that you sort of have doctors, nurses, indigenous health workers, and the odd sort of allied health person that is unlikely to be there on a permanent basis. On the basis of what we could analyse, the numbers for the doctors were really too small to make any definitive statements about, there being fewer doctors in the worst performing communities, only in the sense that the level of statistical significance was a bit iffy. You would certainly suspect that would be the case, but the numbers were too small to be a bit more certain about it. It certainly does seem clear that the poorest performing communities had fewer nurses and relatively more Indigenous health workers as a proportion of their health workforce. And I think it's important to note that this doesn't necessarily imply causality, but it is an interesting observation that you could drill down into this a fair bit. Say, look, those communities that perform the poorest are likely to have a higher proportion of the population who are Indigenous, and therefore are the ones that need Indigenous health workers in the first place. It's an interesting observation, though, that those poorest communities with the highest levels of avoidable mortality had a health workforce comprised mainly of Indigenous health workers. Just for interest's sake, rather than anything else necessarily, we've included two other things at the end there. That SAFER score is essentially a measure of social disadvantage, and we included that really to reinforce the idea that those communities with the highest rates of avoidable mortality were among the most disadvantaged, and that those disadvantaged scores, correlated with the rest of the trends that we saw across those groups. And we included adult volunteerism really on the basis that it was keen to include some measure of the protective effect of living in a remote community. Now, it's far from a perfect indicator, and the opportunities for volunteerism are limited in those places. But this is people who have identified themselves as having some engagement with the community, and we thought that was a not unreasonable measure of the level of social cohesion in these places. And that sort of had the opposite trend to that. Well, it depends how you define it, I guess. The poorest performing communities had lower levels of adult volunteerism, and there you could speculate a lower level of community engagement. Now, this is the factor analysis. I'm not sure of how much interest this is to you assembled, but this is just sort of pointing out that really the contribution of Indigenous ethnicity to those differences between the groups was so strong that we essentially gave it its own category, and then looked at a couple of other factors to see how strongly they explained, in a broad sense, those differences. And basically what we're sort of demonstrating here is that of those sort of 20-odd factors that I showed you before, they can come under a couple of broad headings, broad umbrellas, related to poverty, related to lack of education, related to lack of opportunities for employment. So you could say one's a sort of a poverty factor, and one's a sort of social factor that encompasses things like overcrowding and single parent families and that sort of thing. So there was sort of two key areas that, if you're looking to address these issues from a sort of policy perspective, you'd say, right, one's sort of economic and one's social. Okay, so once we'd sort of had a look at which of those factors was most strongly correlated with the differences in avoidable mortality between those groups, we then did what I think is a pretty interesting step, which is to go back and apply the differences in those factors back to the original list of communities and saying, right, we're going to see what your predicted avoidable mortality would be given what we know about those factors that are present. So, say for example, you have a community with high rates of poverty and overcrowding and illiteracy and unemployment. You say, all right, you would seem destined to perform poorly in terms of your avoidable mortality rates. Based on that, we'll make a sort of mathematical prediction of what your avoidable mortality rate should be, and then compare that to that which has actually been observed. and see how that observed to predicted avoidable mortality rate sort of stacks up, and how the list can sort of shift around. So what we're trying to demonstrate with this is some sort of contrived measure of health system performance in terms of relating it back to that epidemiological risk concept. So to say, which of these communities are sort of doing better than you'd think, or underachieving based on those social factors. And I think there's some really interesting results in here. The new list that was generated by this process had some significant differences compared to the original one, as did the maps. So let's have a look at the maps. Just go back one. So this, I wouldn't expect you to remember the earlier red and blue map that I showed you, but this is the one that resulted from that reshuffling and looking at communities based on their observed mortality rates to the predicted based on their epidemiological risk. Now, there's a couple of things to keep in mind here. One is that these observed to predicted ratios, they may be for communities for which the avoidable mortality rate is not particularly high or low. Do you know what I mean? You don't need to be in that sort of worst 20 communities in terms of your AMR to have a high observed to predicted mortality rate. We're sort of looking at how you should be performing to how you are performing. Everyone with me on that? So there's some really interesting examples of communities here, and I won't go into sort of naming specific communities, but I think of particular interest, I don't have a pointer, but of particular interest are those that, oh yes I do, are those communities that are in close proximity. Say up here, this is a sort of zoom in on the Torres Strait, which is an area quite close to my heart, and you've got two islands here that are side by side. This is Bardu in blue, so that's low observed to predicted avoidable mortality rates. And right next to you, you've got Moa Island, which there's two communities on Moa Island. The one highlighted in red is Kuban community, which we know, empirically to be a basket case. We know that when a patient comes in from Kuban, they're going to be in trouble. It's impossible to get people to stay working at the clinic there. The community is very dysfunctional. And we know that sitting around our doctor's office on Thursday Island, that Kuban is a battler, and that Bardu is not too bad. I was very interested to see that even just based on those few social factors that we looked at, that those differences in avoidable mortality rates are visible at such a zoomed out level for these communities that we know, sort of anecdotally to be quite different. And the same applies for this sort of adjacent Arnhem Land communities there that have very different outcomes. Gumbalunja has very high rates of observed to predicted mortality rates, whereas Nhulunbuy is its neighbour and is doing pretty well compared to what you would expect. Now that's not to say that these communities in blue on this map have low epidemiological risk. It just means that their outcomes are not bad compared to the factors that they inherently possess. Yeah, any questions on that? Okay. Those are those two maps side by side, just to demonstrate two things. One is that there is some significant differences between them. There's some new entrants into the map on the right of those communities that are in the sort of worst 20, those ones highlighted in red that have vast differences in their observed to predicted mortality rates. And the other thing to point out is that some communities haven't changed at all. So say, for example, this particular Arnhem Land community has low rates of avoidable mortality and has its predicted mortality is also low, so it has a low observed to predicted ratio. So it's doing well on both measures, whereas there are others that are blue in terms they have low levels of avoidable mortality, but they disappear. So that means that they are doing worse than you'd expect. And there's a few that go from blue to red, and those are the real worries. These are the ones that we need to really zoom in on and say, what's going on here? You've got low levels of avoidable mortality, but it's still far worse than it should be based on your epidemiological risk. And that's where the real money lies, I think. So from all that, and I want to re-emphasise the idea that we're really just putting this forward as a relatively novel way of examining the situation in these communities. And it's eminently replicable, the technique that we've used. The data is publicly available, but subject to many sources of error, small population denominators, methods of data collection, the reliability of the source and these sorts of things. But despite all those caveats, given that those health outcomes in the most remote communities in the country are so concerning and so different, so much worse than the rest of the country, a within-group comparison of that group of very remote communities reveals important differences, both not just in terms of their outcomes, but the epidemiological risk factors. Of the factors that we examined, the ones that contribute most strongly to those observed differences in avoidable mortality are, broadly speaking, related to the things I mentioned before. They could come under the broad headings of poverty, lack of education, underemployment, and health workforce composition. Now, I know to most of you in this room this will not be, an earth-shattering revelation. The main thing to point out was that this hasn't been this hasn't been well demonstrated before in terms of looking at the group and comparing to each other. And another interesting finding is that the trends within this group are similar to those observed comparing rural and urban communities. Now, in a way, this is a good thing. It means we don't need to think about an entirely different set of variables which contribute to poor health in the most remote communities. But it is interesting that, on a sort of national level, when you compare rural and urban, you get a certain set of factors. When you look at this, small number of very remote communities, vastly different to the rest of the country, yet those same trends still hold true. So, in terms of key findings, I think it's important to acknowledge the elephant in the room as being present, that those communities that came up in red in both maps that have the highest rates of avoidable mortality and the highest rates observed to predicted avoidable mortality rates, they're indigenous communities. Of the very remote communities, they're indigenous. And I think as I sort of got a bit excited about before, the phenomenon of those communities that are in close geographical proximity and are in many ways otherwise comparable, if not identical, but have very different outcomes, it is dwelling on those differences or examining that more closely, drilling down deeper into those, that I think the real value for money lies. Why are there these differences? And okay, we acknowledge again that you're going to have several that are sort of mathematical results rather than true representations of the reality on the ground. But I think in terms of a proof of concept, a new approach of examining the issues in these places, that those differences in neighbours is where some real potential value lies. I know you guys aren't policy people, and it would be unfair of me to overburden you with this sort of information, but I think that essentially acknowledging that resources are finite, and that I'm not suggesting that nothing is being done about these imbalances. Nevertheless, this approach could help identify those communities that are performing poorly and help to address those imbalances. And that's essentially the message that I've just had the opportunity to talk to the Department of Health and Ageing people about, is saying, look, if you identify which communities have worse health outcomes and look at the factors that appear to be related to those differences in health outcomes, in particular the ones we sort of talked about, the broad headings, poverty, overcrowding, lack of education, unemployment, and use lessons from those extremes, from the best and worst communities, to guide strategies to address that imbalance, then that is a strategy that is achievable at a very localised level. For example, there's a health service district level, as well as a very zoomed out macro level. So, doing analysis along these lines can be done by anyone with the information that's publicly available, and can be done for different types of communities, and can be done in different ways. But really, I hate to sound like a boring researcher to say, more research needs to be done, but really it comes down to the quality of the data. To make sort of strong recommendations on the basis of analysis like this, you need to have good data. And so, my hope would be that it would be possible to collect data more specifically with such analytical objectives in mind, so that the results of that analysis would hold a bit more water. Look, I think I've disclaimed enough over the course of what I've said to not need to repeat all this, but I hope you'll indulge me that we have tried to consider the sources of error and bias in the study, and we're not claiming that this is a true representation of the fact, but saying, look, this is a way that this information could be examined in order to highlight important differences and hopefully lead to addressing those imbalances. There's many people that I would have to acknowledge for this, and not least the wonderful team at FACRRM who are here supporting me today, and it's been their guidance and mentorship that's been very helpful to me. Without them, I wouldn't have coped. This is a list of references that I've used. And I would be very happy, since you've all been so attentive and quiet, to talk a little more about any questions or comments you might have about what I've been rabbiting on about.
Does it give you any clues about whether it's delivery of services to these communities versus some sort of policy intervention that enables them to create services that would be the sorts of things that are showing up? And the reason national broadband network, would that make a difference?
I'm not sure I can answer that. I think if I could take a liberty with my response to say that, look, what we've looked at is only a small part of the issues of causality of these differences in health outcomes. So, the sort of socio-economic or social epidemiological variables that we examined are only part of the story. There's many other aspects to it, including health risk behaviours and many other things related to health service delivery. We're just looking at a few very upstream variables, and even the list of those which we examined is only part of the complete list. So, we're only looking at a very small part of the explanation as to why these differences exist. And I think, in a broad sense, anything that is going to lead towards even partial alleviation of those imbalances, poverty, literacy, employment, education, would have some sort of trickle-down effect, I'm sure. Bob?
I think the distinction you made earlier about preventable and amenable sort of gets to that a bit, because some of the amenable ones might be better able to be managed if there were broadband access and that sort of support. You gave example of appendicitis. So it could have some benefit. I don't know what the balance of preventable and amenable is in all those communities, but there must be some benefit if you can at least deal better with some of the ones that are amenable.
I agree, and certainly communication in general in these remote communities is a big issue, and I'm not going to comment on the NBN specifically, but you're right. I think any sort of infrastructure improvement is more likely than not to lead to some improvement in health outcomes. Yeah. Any other questions or comments?
Yeah, I think the comments about poverty, education, etc., being sort of base causal factors, maybe underlying that are cultural issues and degree of alienation from land and all that sort of stuff. And I imagine, I don't know Bardu and Moa terribly well, but it may well be that one of those communities is more alienated from its origins. Maybe it's even shifted from another island. I understand that has happened, that people do move from island to island for one reason or another.
I agree with what you say, and I think that would form part of the logical next step to take this, is to say, okay, we've looked at these differences, we've highlighted some areas that are sort of behaving a bit differently. Why is that so? And you're not just going to be looking at the factors that we examined. There's a lot more cultural and historical sort of backstory to the situation in those places as to why these ones are behaving bizarrely, underperforming, whatever you want to say. And I think if you were to pursue this, then that sort of qualitative analysis would be a major part of that, and it'd be really interesting, particularly even just to visit those communities, to speak to people who have worked there and understand that situation, for them to be able to fill in some context as to why that may be so. I mean, us sort of looking at a map and saying, oh, that's a bit weird, we've got a red and blue side by side, is not to really drill down into the legacy of why that is the case. Yeah.
I think like the outstations movement is potentially interesting in this context, where these very small communities that are often deemed unsustainable have better health outcomes, and it's never quite clear from my reading of the evidence whether it's people who move out there are more culturally connected and more because they're moving there to get back to country, or is it something about the geographical distance from the shops that sell bad food and alcohol and so forth?
Yeah.
I guess it's that sort of actual mapping of what's happening.
I think there's, when you talk about very remote communities and very remote Indigenous communities in particular in Australia, you're really opening yourself up to a flood of comment and not necessarily criticism, but there's issues to do with obviously we're talking about a very migratory population often. even in non-Indigenous communities, you know, the effect of season, of industry on the populations of these areas can be very significant. You know, in terms of health workforce, you've got this concept of the livability or the likability of a place that leads to, you know, retention of staff. And even, you know, in some corners, the idea of the viability of these remote communities being in question. You know, what's the sort of long-term prospects for communities like this that are, you know, sort of seem to be crippled by dysfunction in so many respects. Yeah, it's an interesting field to examine. Any other questions or comments? Yeah.
I'm curious about the distribution of the preventable and amenable deaths by different clusters or what SLA is. Did you try to have a look at that, like where they're similar or where there was any difference?
I looked into it up to the point, like, to sort of be able to justify a decision for choosing avoidable mortality rate as a health outcome. And my reading has led me to understand that, so it's a derived measure or a contrived measure that divides up disease categories in terms of whether they are preventable or amenable, and that comes under the umbrella of avoidable. And that, you know, that's subject to its own sort of caveats. There's some conditions for which that are very rare, so aren't included. There's some conditions for which there are very low mortality rates in the first place, so they're not included. And some for which they're very high mortality rates, like palliative care, so they're not included. So it makes for interesting reading, the sort of list of diseases or conditions which constitute that avoidable mortality sort of group. My understanding of it, in terms of you asking about relative proportions, is that they try and go for a 50-50 sort of split, that they try and basically from the mega list, the master list of diseases and conditions, they try and say, look, you know, if we're going to call them avoidable, then we're going to say they're either preventable or treatable or amenable. And that they sort of try and have this sort of 50-50 split. But as you can imagine, there's many that straddle that divide, that, you know, you sort of think something like cardiovascular disease. Are you going to say that's preventable or treatable or both? Yeah, there's a lot of, you know, I know grey areas is a cliche, but there's a lot of overlap and sort of difficult to define conditions in terms of putting into that group. But I found that last reference at number 9, the Atlas of Avoidable Mortality, very interesting reading to see how this measure is derived, rather than using crude death rates, which don't give you a lot of information, or life expectancy, which is really useful, particularly in an international comparative sense, but isn't used so much for a within-group comparison like this. I know that's not fully answering your question, but I could direct you to further reading in that, and that's sort of my understanding of how it's derived. Yeah.
How do they handle those ones that can be both unavoidable and avoidable?
I think
they just leave them out?
No, they sort of do a 50-50 split with them too. They say, right, okay, if we've got two that we think Australian divide, we'll say one's one and one's the other. It's a bit of mathematical bajiggery. Yeah.
Yeah, I was just wondering about, like you said something about your policy recommendations and all that. So I was thinking along the lines that, okay, you're dealing with remote communities, like is this research gone back? And because, I mean, the utility of this research perhaps you'd like it to be taken up by communities themselves, so that the mortality that we're all talking about will have some sense. And if you actually get anything that from the community perspective,
I haven't really sort of trotted this out to the communities under question, and in fact I'm a bit conscious of on the data that we've been able to examine and the way we've gone about the analysis to really, I'm keen not to emphasise which communities are sort of in the list and where they are on the list. At this stage, I think, you know, you could do so if you felt that your data sources were a bit more robust, perhaps. But, you know, I guess in an informal sense, like I think there's certainly interesting applications of this analysis for where I've been working in the Torres Strait. But I haven't sort of spoken to specific health service districts about how the communities in their region are performing, and I'd be reluctant to do so on the basis of what we've found. This is really just, as I say, a sort of pilot of a way that this information could be examined, and, you know, have just presented that to the government folks, and it's sort of up to point how much they choose to run with this as a concept. Yeah. Any other questions or comments?
Was the factor of the health service availability, was that was one of the social risk factors included?
Not really. I was keen to...
So you separate that out?
Yeah, I was keen to stay fairly upstream. I thought, you could really get into... you can't do any sort of examination of health risk without looking at things like smoking, inactivity and nutrition and the industries that people are involved in and accessibility and availability and appropriate delivery of health service in those areas and all that sort of thing. I sort of look with the particularly the time and resource limitations that we had, we'll just look at this particular set of variables, really far upstream variables, I think, but they're obviously all interconnected. No one's going to argue that economics and education, employment and health aren't connected. But yeah, sort of limited ourselves to examination of those things, included sort of workforce numbers almost as a bit of a sort of bonus at the end, rather than sort of really looking at how the health service is delivered in that area and how that affects health outcomes. So I'll excuse myself from that one, Peter, if you don't mind.
Can I just say, just as an observation, that from what I've heard from the west of Amenable, that since the CDEP program has ceased, there seems what people have observed is a lot more dysfunction, because a significant portion of the population when it was operating used to get up and go to work.
This is the CDP or sort of work for the dole stuff?
Yeah.
Mm.
But now there's nothing at all, and everyone's on the dole and they don't get up.
Yeah.
And all sorts of other things have gone wrong. It just seems like so obvious to me that there's been a change with the change in the employment policy.
Look, I think that the phenomenon of the CDP or the community employment programs in these remote communities obviously has a significant effect on our data, for starters, just as a sort of personal point. Because it is people identifying whether or not they're employed, and yeah, as you point out, the abolition of that program has meant you have a lot more unemployment, but also it's not just the fact that people aren't getting paid because they're still getting the dole. It's that listlessness, that inertia that seeps in. And look, this isn't part of my analysis. I'm just sort of speaking off the cuff now, and as I'm sure many of you know, that it's that sort of situation that inevitably leads to more sort of drug and alcohol abuse and all those other sort of more sinister aspects of societal dysfunction that can emerge. It's an interesting phenomenon. I think we're yet probably to see you haven't seen the worst of the fallout from that. Yeah.
The methodology you've developed seems to be a really interesting way of asking intuitive questions about these communities. Taken a bit further, what's your sort of intuition about the sort of questions that this process will make you able to ask? Not so much, I think it seems to have as much value in the way it determines a sense of questioning why things are happening as much as explaining why they're happening. What sense of that questioning process do you sort of get from your research?
I appreciate you saying that and asking. I think, look, for me, probably the two logical next steps for this to take would be, firstly, as we sort of mentioned previously, having identified those communities that appear to be behaving differently to what you would expect, really drilling down much more deeply into why that may be so. So looking at a broader set of epidemiological determinants, really, getting a better understanding of the culture and history of those communities and why they may be behaving differently, particularly to their neighbours, and doing more a qualitative, kind of mixed methods analysis about those observed differences is one direction. I think the other obvious direction for it to take is to say, look, okay, we've used this as a proof of concept for the very remote communities, acknowledging all the potential sources of error and issues surrounding that. Could we legitimately, in terms of methodologically legitimacy, apply that to other geographical areas? So is this sort of analysis relevant? Does it make sense to do it for remote communities, for inter-regional communities, for cities? And that's really where FACRRM comes in. It's one of their big strengths is in doing that sort of analysis, and the way they're developing their GIS capacity would potentially lend itself to doing some really very small scale and sophisticated analysis of the differences in areas, you know, even in a suburban setting, down to quite a specific localised scale with small numbers. And in fact, it probably gets easier in that setting than talking about, you know, you look at some of the maps I showed you earlier, these SLAs of only a few hundred people cover vast areas, and they're sort of not exactly abstract boundaries, but certainly the boundaries don't necessarily represent true geographical or social divisions. So yeah, they're the two directions that I think this type of methodology could take, as well as the obvious one of going back and doing this again with better and more complete data. Yeah, but I appreciate your support for the methodology. We think it was interesting, but we acknowledge that it has some inherent flaws as well.
Could I just add a comment to that? Because I think, I think the second option is one that interests me in terms of applying it in other areas. One of the huge challenges of doing that is the publicly available data, in that at the moment the publicly available data is at SLA level, and that is functionally meaningless if you look at it if you're trying to do really small area analysis in an area like Canberra. And we know there are disadvantaged communities in Canberra, but we also know that on the whole we have a heterogeneous, very well-off community, and sometimes those disadvantaged communities get very much hidden. And if we could get the really disaggregated census block data, then we could start doing exactly this sort of thing within the ACT or the South East New South Wales region. The challenge we have with that is getting the access to the census block level data. I think this is why this, to me, is a very exciting tool to use, because I think with geoanalysis and geocoding, we can actually, if we can persuade the data custodians, that we can get small local area data and still protect individual privacy. For instance, if you've got census level data, you can randomly allocate a point location within a 100 houses region, so that you don't know which of those houses it is, but it's still quite a small area. And to me, this is one of the real attractions of both the mapping capabilities and the spatial analysis capabilities. Is I think it does offer us a potential way forward to start looking at small area data, but still protect individual privacy.
Yes.
Have you thought about using the same methodology to do avoidable hospitalization?
It would certainly, I imagine, be theoretically possible. Hospitalisation data is available. For these very remote communities, once you start talking about hospitalisations, you really got to be very careful with your population denominators, because usually people are hospitalised outside their own communities. But I think certainly, and look, the whole idea about doing observed to predicted ratios, as I'm sure you're aware, is not novel. It's doing it in this context, which perhaps has not been done so much. And I think hospitalisations is a very interesting health endpoint in itself. And I think for health service districts, even in sort of rural areas, for their specific hospitals, this is an interesting way of looking at the data. Certainly the upstream variables are going to be there, and if you have hospital data to compare with, there's nothing stopping you doing a similar style of analysis to look at avoidable hospitalisations, and that's certainly done elsewhere.
And Vic Health has done some mapping of their avoidable hospitalisations. I don't think they've taken to that next level of comparing the observed to predicted, but they're certainly starting to look at some of the mapping issues.
Any other questions, comments? Thank you very much for your attention.
majority will be okay. So I've kind of had that background in finding some of educational resource. GPs don't use it, they don't access it. So now the people I'm working with Sylvia and John and I and Phil Whistler doing this kind of national studies project looking at